My name is Tapan Kadia. I'm currently a professor in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. And I'm delighted today to be invited to speak on the evolving paradigm in the treatment of newly diagnosed acute myeloid leukemia. So as you all know, the treatment of AML has changed drastically just in the last 5 years, based not only on the recognition of the genomic heterogeneity of AML, but also on the development of new targeted therapies for each of these individual genomically defined subsets. And as a result, we've been moving away from treating everyone with a one-size-fits-all approach with intensive chemotherapy, followed by high-dose cytarabine, followed by transplant, and are looking more into how we can treat each of these patients based on their baseline genomics, based on their fitness, and then trying to explore different opportunities once they're in remission, whether it be allogeneic stem cell transplant, whether it be maintenance therapy, or whether it be allogeneic stem cell transplant followed by maintenance therapy in order to prolong remissions and therefore overall survival. So much of the landscape of AML has changed because of the better recognition of the heterogeneity of our patients, not only based on their genomics, their cytogenetics, their molecular analysis, but also on the actual patient's comorbidities, performance status, their prior history, their ability to tolerate intensive or lower intensity chemotherapy. And because of the availability of new agents, we no longer have to sacrifice efficacy for safety. In the past, we thought that intensifying therapy led to increased activity, but also came with the harbinger of poor safety, increased early mortality in these patients. But now, with more effective drugs, we're able to combine those with lower and lower intensity chemotherapy agents and still achieve the same efficacy that we were achieving previously only by intensifying chemotherapy. And so our approach to acute myeloid leukemia now involves assessment of the patient characteristics, including age, comorbidities, performance status, prior history of radiation or chemotherapy, whether these are therapy-related AMLs, and then a comprehensive profiling of the AML, including not only morphology and immunophenotype, but also cytogenetics and molecular analysis, which then allow us to choose their therapy. We always prefer front and center to consider patients for clinical trials because not only do we learn, but they get optimal care with close follow-up and innovative approaches. And then we sort of divided patients into those who we think are eligible for intensive chemotherapy or those who are not eligible for intensive chemotherapy, and then try to look at their baseline genomics to see if we can categorize them into a certain subset where we have data that there is a targeted agent or a type of therapy that will lead to the best outcomes and the best overall survival. And this is just a schematic showing how we look at these in a very broad way, and I'll get into some of these details as we go on. But as we move from getting people into remission to looking at post-remission therapy or even post-transplant maintenance therapy. So the first thing I think we need to touch base upon, and this is essentially going over how we have evolved therapy at MD Anderson and how some of this is being adopted across the United States and even across the world. I think there still is a role for intensive chemotherapy, and indeed, in many of our young fit patients, we still use intensive chemotherapy. And I think one of the key areas where we use intensive chemotherapy the most are those patients with core binding factor AML. Those patients who have anywhere from a 60 to 80% long-term cure rate with intensive chemotherapy, and particularly with the addition of Gemtuzumab, Ozogamycin. And so, as you know, this meta-analysis showed that the CD33 antibody-drug conjugate, Mylotarg or Gemtuzumab, does show a significant survival benefit, not only in intermediate, but also, and more importantly, a large survival benefit in those people who have favorable karyotype acute myeloid leukemia. And so, therefore, our frontline regimen with intensive chemotherapy, predominantly even in patients who are older and unfit with core binding factor AML, is the combination of FLAG plus GO. For a while, we were using anthracyclines in this regimen with FLAG and idarubicin, but we've moved toward this FLAG-GO regimen, still providing the high-dose cytarabine with 2 grams per meter squared of cytarabine, but adding the Gemtuzumab at just 3 milligrams per meter squared on day 1 during induction, and then once again during cycles 2 and 3 and cycles 6 and 7 for a total of 3 doses during induction and consolidation. And we have achieved with that a long-term overall survival of 5 years of 60 to 80% in most of our patients. You'll notice here in the regimen that even in patients above 65 or those who are older and unfit, we do provide intensive chemotherapy with GO and reduce the dosing by number of days of chemotherapy or with the dose of the cytarabine, but still able to achieve long and long-term correlates. This showing how you can take an antibody-drug conjugate, incorporate the chemotherapy, and improve outcomes in this. When those patients were unable to tolerate intensive therapy or still unfit, we are considering using hypomethylation such as decitabine with Gemtuzumab. Again, not sacrificing efficacy for safety in this patient population. And this is a study done in our group many years ago. And you can see in the untreated AML and MDS a CR/CRI rate of 45% in a very unfit population. So the use of neuron-targeted therapies to augment responses of low-intensity therapy. In newly diagnosed fit patients with AML, our current backbone is CLIA, which provides the combination of idarubicin, hydroxytarabine at a dose of 1.5 grams per meter squared with Venetoclax. Now, CLIA has been our backbone regimen, but now with our experience of Venetoclax in lower intensity regimens, we are now able to add it to intensive chemotherapy such as FLAG-IDA, and here with CLIA, augmenting the response rate, so achieving a higher proportion of remission, but also deeper remissions with high rates of MRD negativity, which potentially may require less consolidation and send patients to transplant earlier, potentially in better shape. And you can see the dose and schedule here of the induction and consolidation. We recently published our data in Lancet last year, and what we found, if you can look at the middle column here, with CLIA plus Venetoclax in 41 patients, a complete remission rate of 85% and a CR/CRI rate of 95%. So virtually every patient that we put on trial, 39 to 41, responded, and you can see 94% of those patients were MRD negative at the time of remission, suggesting that not only are you getting a higher proportion of remissions, but more patients are going into MRD negative states. And so you have now a situation where you are confident that you can get a person into remission safely. And you can see here the mortality rate, 0% 4 and 8 week mortality. Again, we incorporate full antibiotics in our patients. We keep them in negative pressure filter air rooms for the first 30 days. We monitor them very carefully and then consolidate them accordingly. You can see on the right side is also our experience with the FLT3 inhibitor in combination with CLIA and Venetoclax as we incorporate FLT3 inhibitors with this incorporated intensive therapy regimen. And this is the survival. You can see censored for allogeneic stem cell transplant with the median survival is not reached, and a 12-month survival with a median follow-up of 20 months of 80% or more, suggesting improved outcomes. And again, longer follow-up and more patients are needed, but certainly an excellent signal of early activity. Similarly, in those patients who are FLT3 mutated, we are combining Gilteritinib, the FLT3 inhibitor, with CLIA for newly diagnosed patients who are fit with FLT3 mutated acute myeloid leukemia, with here a 12-month survival of about 60 to 70% in this difficult disease subset. What about lower intensity therapy? I think the majority of our talk these days and the majority of the patients that we see in the clinic are those who are older and unfit. We know that in these patients, there are not only patient-related factors such as decreased organ reserve, comorbidities, and performance status in older patients, but we know that the disease in older patients is different than what we see in our younger de novo patients. Older patients tend to have adverse karyotypes, secondary AML, adverse mutations. It's just a different type of AML that we see in our younger patients. And so intensive chemotherapy may not be appropriate for these patients. And fortunately now, with the discovery of drugs like Venetoclax, IDH1, IDH2 inhibitors, and FLT3 inhibitors, we're able to provide lower intensity therapy that's safer, has better tolerance, less early mortality, but still has significant efficacy, as I'll show you some of the innovative strategies that we have implemented. And so less intensive regimens and biologically targeted approaches have been sort of the mainstay. And in addition to that, older patients are often not eligible for post-consolidation transplant options because of their age, comorbidities, and potentially lack of donor, and maintenance therapy plays an important role there now that we have availability there. So just as a background, we know that the treatment of older and unfit patients previously has been with hypomethylating agents, with response rates in the range of 20 to 30%, with a median survival in the range of 7 to 10 months. With the discovery of Venetoclax in the VIALE-A trial, we know that the response rates, the CR rate has increased to 37%, with a median overall survival of 14.8 months. And you can see here the same data showing a significant survival benefit, leading to the approval of Venetoclax in combination with HMA for newly diagnosed patients 75 years of age or older, or those deemed unfit for intensive chemotherapy. So how can we build on that? How can we build on HMA Venetoclax? For years at MD Anderson, we've been using a low-intensity double nucleoside therapy doublet with Cladribine and low-dose cytarabine, alternating with an HMA This is one of our recent publications looking at 250 patients, almost 250 patients, with a median follow-up of 5 years. And in these patients, without the use of Venetoclax, we demonstrated a CR/CRI rate of 66% and a median OS of 12.5 months. This is, again, without the Venetoclax. So we said if Venetoclax can improve outcomes in HMA, what if we add Venetoclax to the Cladribine lotus-Ara-C backbone? And this is the dosing strategy here. This is the long-term program. We give 2 cycles of Cladribine plus lotus-Ara-C plus Venetoclax, alternating with 2 cycles of Vidaza plus Venetoclax, all the way up to 18 months. Now, very few people actually get to 18 months because they achieve such great remissions early on. Many of them move on to maintenance therapy, and many of them become eligible for stem cell transplant and move on to transplant. And so we give Cladribine for 5 days, lotus-Cytarabine for 10 days. Again, the first cycle is in the hospital, and we give Venetoclax on days 1 through 21, adjusted for appropriate CYP3 inhibitors. And recently we presented our data at the ASH meeting in December, and of the 60 patients, and this is the completed trial, we demonstrated a CR/CRI rate of 93% with 80% complete remission. That's CR with complete count recovery in 80% of patients. And importantly, with this lower intensity therapy in this population with a median age of 69 years, we found 84% of patients were flow negative for minimal residual disease at the time of complete remission, suggesting deep responses. And you can see here 4 and 8 week mortality of anywhere from 2 to 7% in this older population. So a very active therapy, a low intensity therapy that can potentially get people for allogeneic stem cell transplant. And this shows you the survival with a 12-month survival of 73%, which was maintained in many of the different subgroups. And particularly in the favorable ELN subgroup, you can see excellent outcomes with greater than 90% long-term survival. But even in those who are intermediate and adverse by ELN, you can see the 12-month survival over 60% in a population where the median age was 69 years. And so this is a regimen that we are moving forward in patients who are anywhere between the ages of 60 and 70 years of age. Those patients who presumably could be fit for intensive chemotherapy, but a lot of us are uncomfortable giving that even in those patients. And so we are using this therapy now to achieve high response rates and still taking them to transplant, but in relatively good shape. We're also going to start studying this in older patients, as well as even younger patients, those age 50 and above. Now, can we push the age down and provide excellent therapy, good efficacy with a safety profile? We are also expanding the Cladribine LDAC as a new backbone, combining with FLT3 inhibitors in patients who are FLT3 mutated, with enasidenib or ivosidenib, with Gemtuzumab in patients who are poor binding factor or favorable karyotype. And these are considerations for those so-called younger older patients, those who are between the ages of 60 and 75, or those who are unable to receive anthracycline, for example, but they can still be taken to transplant in excellent condition with less toxicity, for example, with anthracyclines, the mucositis, the GI toxicity, etc. And you can see this is just a review of our outcomes by regimen: IA or idarubicin, cytarabine, CLIA, Venetoclax, AZA-Ven, and then Cladribine lotus-Ara-C-Ven, which is the lower intensity therapy. And you can see here the CR/CRI rates are actually very similar, even with the low to moderate intensity regimens, with high rates of MRD negativity, suggesting that we may be able to move down in our age group with these newer strategies and innovative approaches with the addition of things like Venetoclax to previously active regimens. This is just a very nice review, and you might want to look at this by Dr. Maiti and Dr. Konopleva from our group, looking at how we have added Venetoclax to different regimens, whether it be HMAs, lotus-Cytarabine, Cladribine, lotus-Cytarabine, or intensive chemotherapy such as FLAG-IDA or CLIA. I think it's important when you look at patients who are receiving Venetoclax to remember that this is a drug that can cause significant neutropenia and lead to infections and sepsis. And so we are always implementing prophylactic antimicrobials, prompt and aggressive treatment of infection, growth factor use when needed, but also delaying therapy cycles when it's appropriate, prolonging cycles if appropriate, and so on when needed. What about going into IDH-mutated AML? It's in the same subgroup of people who are low intent or older or not qualified for intensive chemotherapy. We know that IDH1 and 2 inhibitors are approved for relapsed and refractory AML with overall response rates in the range of 40 to 42% as single agents. What about bringing this to the front line? And indeed, that's been done. We know that there's a clinical trial looking at AZA plus or minus enasidenib, which demonstrated significantly improved rates of overall response of 71% compared to 42% for azacitidine alone, and a complete remission rate of 53% compared to just 12% with a median event-free survival of 17.4 months. So you can see a significant improvement in event-free survival, maybe not overall survival because many of these patients were salvaged with enasidenib in a sequential manner once they failed the single-agent azacitidine. And so clearly, in the front line in IDH2-mutated AML, there is potentially a role for the combination of azacitidine and enasidenib. Recently at the ASH meeting, there was a presentation on the AGILE study, which looked at AZA plus or minus ivosidenib in patients with IDH1-mutated AML. And what they demonstrated is that the combination of ivo plus AZA demonstrated a significantly improved rate of complete remission of 47% compared to 15%, and a CR/CRh of 53% compared to just 18%, and also higher rates of clearance of MRD by molecular testing. So really improved response rates with the combination of ivo plus AZA, and again, very importantly, what you see, next slide, is a significant improvement in overall survival with the combination of ivo and AZA compared to azacitidine alone in IDH1 mutated AML, likely allowing this drug to move forward, hopefully in the future, as a frontline treatment in patients with IDH1 mutated AML. And so the theme continues, right? AZA was the original sort of low intensity treatment for these older unfit patients. We added a drug that's active in a subset which responded to that. Now we're able to maintain safety but drastically improve efficacy and thereby overall survival. We're moving further on that by providing a triplet regimen, looking at the combination of ivo plus AZA plus Venetoclax. This is led by Dr. DiNardo in our group. Again, this is the study design, and preliminary data show excellent response rates with composite CR rates of 92% in frontline AML, MRD negative remissions of 60% in IDH1 mutated AML, and with rates in older unfit people which have not previously been seen. So using targeted therapy and leveraging that to improve efficacy while maintaining safety. And these are some of the survival curves. Again, you can see excellent one-year survival of 80 to 100%. In FLT3 mutated AML, similarly, we're using these backbones. I mentioned the Cladribine Lotus-ARC backbone, but we have historically used HMAs as the backbone and combined them with TKI such as midostaurin, sorafenib, and now Gilteritinib and quizartinib. But with the new backbones, such as AZA plus Venetoclax, we're able to use triplet combinations where we combine AZA plus Venetoclax plus Gilteritinib in FLT3 mutated patients who are ineligible for intensive therapy. We know from safety data, again, this is work by Dr. Dalver in our group, that certainly Venetoclax combined with Gilteritinib in relapse and refractory AML does show significantly improved rates of marrow complete remission. We saw that it was safe, and based on this, triplet regimens have been developed combining HMA with Venetoclax with FLT3 inhibitors, and these are ongoing. This is a study from our group looking at a combination of decitabine plus Venetoclax and a FLT3 inhibitor in those patients who are FLT3 mutated. And on the left column, what you'll see is a complete composite remission rate of 92% and a CR rate of 75%. And on the right, you see excellent long-term survival in the top curve and the blue curve in newly diagnosed AML with a one-year survival in the range of 80%. Now, small numbers, just 12 patients, but these studies are ongoing and the data will be maturing, but we've shown that it is safe, and we see this sort of being the future of how we treat patients who are potentially with FLT3 mutated once we find out the appropriate dosing strategy to make sure that it is safe for our patients. A recent analysis by Dr. Yilmaz looked at our historical experience, looking at a doublet of first-generation TKI such as sorafenib or midostaurin combined with HMAs, second-generation doublets such as Gilteritinib again with HMAs, and then you see the green curve showing the triplets. So not only do we see improved response rates, but a stepwise slow improvement in overall survival over the years as we're adding TKIs to newer and newer backbones with the Venetoclax. And I, again, emphasize that it's important for us to make sure that we do this in the setting of a clinical trial, understand the safety profile, and make sure that we adequately study the doses and the schedules, whether it be 14 days of Venetoclax, 14 days of Gilteritinib for cycle 1, and then followed by lower doses of Gilteritinib during future cycles, less days of Venetoclax, because these do provide increased levels of myelosuppression that need to be monitored throughout time. P53 mutated AML, that has been one of our biggest challenges. Unfortunately, Venetoclax, although it does improve outcomes in many subsets, does not seem to improve outcomes in P53 mutated AML. We went back and looked at our experience with P53 mutated AML, looked at therapy with or without Venetoclax, and again, although the response rates are slightly higher with Ven, there was no significant improvement in RFS or overall survival. New drugs such as immune therapy, such as Magrolimab, which is a antibody against CD47 and its interaction with SIRF-alpha, allowing the macrophages to engulf the tumor cells, is being currently studied. With early preliminary data in MDS and AML that was P53 mutated that showed a very high rate of overall response in P53 mutated AML, which was a bit unusual, right? Because you typically expect response rates in the range of 40 to 50%. And based on this, several randomized studies are ongoing, looking at the combination of AZA plus or minus Magrolimab, and more recently, a combination of AZA plus Venetoclax plus Magrolimab, which has shown very promising results and was recently reviewed at the American Society of Hematology meeting in December. So these studies are ongoing, certainly trying to figure out new ways to target P53 in a mutation-agnostic manner. That is to say, you're not targeting P53, but you're targeting the disease by engaging the immune system, a mechanism which doesn't really require the active P53 protein to lead to cell cycle arrest and apoptosis as it would with chemotherapy. And finally, I want to touch upon maintenance therapy. I think this is one of the biggest advances. We've been trying to figure out a way to do maintenance therapy in acute myeloid leukemia, and certainly the Quasar trial demonstrated a significant improvement in overall survival when patients were treated with CC-486, which is the oral form of 5-azacitidine in patients with acute myeloid leukemia who had received induction chemotherapy and were not able to complete their consolidation therapy. You can see here an improvement in OS from 14.8 months to 24.7 months with the addition of CC-486, which is now the standard. We have tried to go beyond that, and what we're doing now is studying the combination of azacitidine at a lower dose. You can see there 50 per meter squared for 5 days, combined with Venetoclax, either for 7 or 14 days, and the doses you can see there are adjusted for CYP3 inhibitors, and we want to see what the relapse-free survival is. And we've been treating patients in this manner and presented our data recently at the ASH meeting. And what we found is that the relapse-free survival was significantly better than what we would have expected based on our historical cohort. So in the full cohort, the median relapse-free survival was not reached with a 1-year RFS of 65%. And on the right, you can see that the median OS was 16.1 months. And these are patients who received induction, consolidation, but could not move on to allogeneic stem cell transplant. And this study is ongoing, and we're trying to build on this to determine the best dose and schedule and whether this improves outcomes compared to what would be historically expected in a high-risk population without allogeneic stem cell transplant. We have stratified by patients who received intensive or lower intensity therapy to see how patients who have received intensive chemotherapy, for example, would fare if they received AZA-Ven as maintenance therapy. We also are now engaging in the use of tyrosine kinase inhibitors in patients as maintenance therapy. We know that there are 2 big studies looking at the TKI Sorafenib, which inhibits FLT3 and other kinases in patients after stem cell transplant. And so the SORMAIN trial here in the randomized phase 2 study showed significant improvement in PFS and overall survival in patients post-transplant with or without sorafenib. The second study from China was a randomized phase 3 study looking at 202 patients with patients with a median age of 35 years who received either sorafenib or placebo and demonstrated a significant improvement in OFS, LFS, and reduced incidence of relapse among patients who are FLT3 mutated, suggesting a strong role for sorafenib in this setting. We know that Gilteritinib is being studied as well as midostaurin in this setting. And so what we have developed now is a trial looking at oral therapy, oral HMA, such as 5-azacitidine or oral decitabine, combined with different targeted therapies based on your baseline mutational profile as maintenance therapy once you achieve a remission. So you would have a person who is FLT3 mutated, who receives induction, is in remission, gets consolidation therapy, and then moves on to oral HMA from Gilteritinib or oral HMA with enasidenib in those 2 people who are IDH2 mutated, ivosidenib and IDH1, or oral HMA alone, those patients who are not sort of classified by a particular mutation. So that study is open and ongoing, and we hope to see some nice results from that. And so in summary, I think the key points is that there are several options for delivering effective therapy safely to patients, even those who are unfit for intensive chemotherapy, newer backbones of targeted therapies. I think it's important to remember that AML therapy is long-term total therapy with genomic characterization at the start, incorporation of targeted therapy, close follow-up, dose modifications, and therapy modifications throughout. It's a constant surveillance. And then maintenance therapy, I think, it should be incorporated not only in people who are ineligible for transplant, but also those who are post-transplant. So I really thank you for your attention. I'm happy to take questions. Thank you very much.